Thank you everyone who is here this morning to attend this training on Comprehensive Geriatric Assessment. My name is Nirmala Dhar, and I'm a licensed clinical social worker with 35 years experience in behavioral health. I work for Oregon Health Authority, and I'm the project director for the Older Adult Behavioral Health Initiative that Angela is a part of, along with 24 other specialists across Oregon. And one of the core functions of this initiative is to bring training such as this to develop a workforce which is better able to identify and treat the behavioral health needs of older adults and people with disabilities. So thank you for inviting me, and I would just like you to move on to the next slide. So my learning objectives, by the way, Leonardo da Vinci said, learning never exhausts the mind, and I am a firm believer in lifelong learning. And my learning objectives for today are what is the definition of a comprehensive geriatric assessment? So it's a kind of assessment. My hope is that you will understand the importance of such an assessment. You will know what are the core domains of a comprehensive geriatric assessment. You will learn about useful tools that are used in your evaluation. And most importantly, I didn't put it down here, my hope is that you take this knowledge and this new learning and apply it in your practice. Or better still, take it back to your organizations, your clinics, your medical systems, and talk about the need for a more comprehensive geriatric assessment for your older adults. And that is really part of the purpose of this initiative too. So thank you for being here. I recognize many names on the list when I looked through the participants. Some of you have been my friends and colleagues for many years, so welcome. Next slide. So I'd like to begin with just a case study. And I'd like you to keep this, I'd like you to keep Karen in the back of your mind throughout this presentation, because we will come back to Karen at the end. So Karen is an 85-year-old woman who lives alone. And a week ago, she fell down the stairs in her home. Since the fall, she walks very slowly while holding on to furniture constantly, does not want to leave her apartment, is not really eating well and losing weight, and is calling her daughter anxiously every day, several times a day. Her daughter brought her into your clinic for an evaluation. All of the physical examination is normal. You know, she doesn't have any significant bruising or pain or broken bones, so it's all normal. How would you evaluate this client or this patient? So I'd like you to keep Karen at the back of your mind. Next slide. And before we really dwell into, dive into what is a geriatric assessment, I just want to also highlight this new nationwide initiative to transform health systems into age-friendly health systems. And why am I highlighting it? Because our population is aging, or in 10 short years, or 1 in 5 Oregonians will be an older adult, age 65 years and older. So why not we be proactive and start looking at how are our health systems age friendly, or how is my clinic age friendly, or how is my home health agency age friendly, or is my community mental health program age friendly? And so this framework has what we call 4 M's. The first M is what matters. So matters. Know and align care with each older person's specific health outcome goals and care preferences. Not just limited to end of life care, but really what brings them meaning and purpose? So how are you going to align those goals with that? And think about Karen, okay? Medication is the second M. Is medication necessary? If it is, use age-friendly medication that does not interfere with what matters to the older adult, with mobility or with mentation across settings. So this is not just for large health systems or, or insurers or payers. It is for all of us. Next M is mentation. Prevent, identify, treat, and manage dementia, depression, delirium across settings of care. And lastly, mobility. I call mobility the holy grail of aging. Ensure that older adults move safely every day in order to maintain function and to do what matters. So the 4 M's framework is what matters: medication, mentation, mobility. And this essentially means your entire system of care, whether large or small, takes into account all of these 4 factors at every visit with an older adult. So my challenge to you is to take this back to your organization, to your clinic, to your health systems, and talk about the 4 M's framework. And keep Karen in mind, because we're going to come back to her looking at this 4M framework. The next slide. So what is a comprehensive geriatric assessment? And that's why you're all here today. And some of you have lots of experience in this. So I'm happy that you're here, and please put your comments in the box. So to start with, it is multidimensional, it is multidisciplinary and evaluation process. So it looks at multiple dimensions of a person's life, not just their clinical symptoms. And there are several disciplines involved in the evaluation process. The goal is to determine if a frail older adult's medical, psychosocial, and what are their medical, psychosocial, and functional capacities and issues. So what are the issues in all of these dimensions? The objective is to develop an overall plan of care and long-term follow-up towards that plan of care. And apparently this concept actually was started in 1930, so it's been around for almost a century, and now is regarded as the technology of geriatric medicine. Whether you're a geriatrician or a geriatric social worker or a geriatric psychologist, or whether you are a generalist, this is the technology of geriatric medication. That is, if you are working with an older adult. Next slide. So this is an imperative, this comprehensive assessment, because I just told you our population is aging across the United States. And in Oregon, there are several rural counties which already look like Oregon in 2050, where more than a quarter of the adults in that community are older adults, and some of those counties are in Central Oregon and also very close by in Eastern Oregon. So this is the imperative. A comprehensive assessment involves looking not only at disease or symptoms, as we do in a standard assessment, or at disability, but at a range of domains. So it doesn't just look at disease and clinical symptoms, or disability, or is there potential for rehab, but it really looks at the range of domains, and more importantly, how do these domains interact? Next slide. And so the components, again, of a comprehensive geriatric assessment, it is multidimensional, meaning that it takes into account not just the medical or the mental health diagnosis, but also functional impairments and the environment and social issues which affect the person's well-being. Think of Karen. It produces a problem list and develops goal-driven interventions to tackle all of these, not just the medical diagnosis. It involves an interprofessional team. Sometimes we call it multidisciplinary. Interprofessional is another term. Each team member brings their own professional specialty, their own professional lens to the assessment. Look at the next slide, please. And look at here, these are, I just found this slide and it just totally illustrated what I've been saying for the last 5 minutes. The 10 areas to assess function and social needs in older adults, and I would say in any complex care patient or client. Your daily living skills, your potential for abuse, to protect yourself from abuse, your home environment, your memory, your health literacy, fall risk, your finances, your social support, whether your caregivers are stressed and burnout, social isolation. So can you see, not only are these areas laid out for us, but they're all interconnected or interlocking in this puzzle. And I think this really illustrates in a very beautiful and colorful way what drives a comprehensive geriatric assessment. Next slide. And so here are some of the domains which should be covered in and we're going to go with them, but I'm just giving it to you in a nutshell. Physical medical conditions. Most often, that's why they show up in your clinic or in your emergency room or in your specialty care or, or wherever you see them, are the physical medical conditions. You look at what are other diagnoses, what is the severity of the disease, you look at medications, you look at nutritional status, you look at the problem list. Mental health conditions, you look at cognition, mood and anxiety, whether there are any fears or phobias. Functioning, you look at core functions such as mobility and balance, activities of daily living, life roles that are important to the patient. Remember the 4 M's? Here, what matters would be very key. What life roles are important to this patient? Because that's what will drive creating that plan. Social circumstances. What are their social networks, informal or formal, available from family, from the wider network, from faith communities, statutory care, what is their socioeconomic status? All that will impact how they are presenting. And then environment, the home environment, use of potential telehealth technology or technology, transportation, accessibility to local resources. So can you see, it is much, much broader than just medical diagnosis. Next slide. And here are some, and I'm not going to go over all of these questions. You will be getting this, handout, and my citations are there too. So here are some questions to ask to assess function and social support. For example, I'm just going to go over, say, daily living. Do you need help with any of these actions or activities? And, the person has to say yes or no. It could be walking, washing dishes, doing housework, making meals, so they'd write yes or no. Look at home environment. Can you live safely and move easily around in your home? If not, does the place where you live say yes or no? Good lighting, good heating, rails for any stairs or ramps, a door to the outside that locks, elevator. All these are questions which you will routinely ask. It should be the standard of care when you are doing a geriatric assessment. And then health literacy. I would like to ask you about how you think and manage your health conditions. Do you need help taking your medications? Do you need help filling your health forms? Do you need help answering your questions? All of these are critical questions to ask. And then next slide. And it goes on to ask questions about social support, caregiver stress, potential for abuse and neglect, memory, falls risk, which was critical for Karen's case, their finances, and then social isolation. My suggestion would be any of you who are interested in creating an age-friendly health system to maybe take a look at this set of questions to see whether this could be something you could be including for all of your older adult clients, patients, that you would be asking this multi-dimensional questionnaire. Next slide. And remember, multidimensional, this is a fabulous, I think, graphic about what is a geriatric, comprehensive geriatric, and I've added functional assessment. So essentially, that's what we all want, right? We want to be able to function well in all of our roles, live in our home. What impacts that? And this is what a geriatric assessment looks at. Your psyche, your physical environment, your social networks, your socioeconomic status, what is the quality of life you want, your physical health, your gait and balance, your cognitive status, your behavioral and mental health status. All of them impact your functional state. So imagine if you only looked at physical, if you only looked at physical for Karen, the 85-year-old woman who fell, and you developed your plan only around the physical. Hey, she has no broken bones, no bruises, so goodbye, you can go home. We would be negligent at the least, if not medically inappropriate in our assessment, because we fail to assess all of these other areas. So I just want you to take a look at this. How many of you use this kind of a comprehensive approach to when you're doing an assessment of your older adult clients, patients, consumers? So next slide. And so remember I talked earlier that it is an interprofessional team. So basically a comprehensive geriatric assessment is a team sport. By necessity, it is interprofessional or multidisciplinary. It cannot be practiced by only a geriatrician physician or a nurse practitioner or a therapist in isolation. The team may vary in its composition depending on what your setting is. However, the principle is that most studies report the core team should involve a physician or a nurse practitioner, not necessarily a geriatrician. They're hard to come by. A nurse, an occupational therapist, a physical therapist, a social worker, a mental health therapist. And I can see all of you kind of worried, oh my gosh, I don't work in a practice like that. Work with the interprofessional team that you have. The point is that you cannot just use one lens, one professional lens to really create a care plan that would be meaningful to Karen or to your older or to your older clients. Next slide. So what does this team do? It looks at multiple problems that interact. Remember, I showed you the slide of those interlocking puzzle pieces. So it looks at multiple problems that interact. And then they look at each of these interactions, and then they identify current and future problems. Again, think of Karen, and we're going to talk about her at the end. Next slide. So again, I am just reiterating it. It is a multi-specialty team. So it's not only interprofessional, but each person on the team brings their own special knowledge. For example, let us consider, say, a patient with Parkinson's disease, incontinence, and recurrent falls. The physician will have to have sufficient expertise to consider the wide array of pharmacologic treatments available for this person. The nurse will have to understand how to assess incontinence in frail older persons and have a sufficient understanding of the impact of cognition and mobility upon continence to hold this, a constructive discussion with the team. The physical therapist and the occupational therapist will have to understand the specific disturbance of postural instability, gait initiation, that is all part of Parkinson's disease. And the increasingly specialized array of physical interventions these individuals need. And I would also add, as a social worker, may need to work with where do we get those resources for this client that to improve their quality of life, and maybe also look at what are the behavioral health impacts of this illness. So you can see how important it is to have this team and that each one brings their specialty knowledge to the team. Next slide is, so what are the core principles of a comprehensive geriatric assessment? We focus on function rather than disease. You know, in more traditional settings, it would be disease. Let's just get the disease under control. Here, the focus is on function. So controlling the disease serves the purpose of improving the function. So for example, if you're going to give whopping doses of a medication to control the disease, which actually impacts function and it actually leads to declining function, that would not really serve the principle of CGA. So you focus on function rather than disease. You focus on palliation versus cure. So cure is not always the goal. You focus on goals of care. Remember, we talked about what matters in an age-friendly system. What is it that the patient and the patient's family collaboratively want? What's important to them? It could be that I want to walk at my granddaughter's wedding. Now, that's not a medical cure, right, for some disease, but that would be the goal of care. And how does the entire team then work around that goal? In a CGA, quality of life is paramount. And we all know that your ability to function, mobility, locus of control are all indicators of autonomy, are all indicators of good quality of life. IATROGENESIS, that means we as healthcare professionals are cognizant and aware that at no time do we actually create problems by the health interventions that we are promoting. Polypharmacy, that in principles of CGA, we look at geriatric medicine, which is less is more, go slow, all of that. And is it serving the purpose of improved function? Is it contributing to this person's goals of care? Is it palliative versus curative? All of that. And then, very important, really looking at the interaction of the social and the environmental. So these are core principles of geriatric assessment. So what is iatrogenesis? Next slide. I just want to spend one slide on it. It comes from the Greek word iatrogeny. That means any pathologic alteration caused to a patient by inappropriate practice of health professionals, which results in harmful consequences for the patient. What are some risk factors for iatrogenesis in older adults? Drug-induced. There are multiple medications. No one is talking to each other, the prescribers. There is poor coordination of care. Multiple chronic diseases, multiple physicians, multiple hospitalizations or surgical procedures. All of that actually are huge risk factors for iatrogenesis. And the good news is iatrogenesis is preventable. So I would challenge all of you to introduce this term into your lexicon when you go back. And with every older client, especially your frail older client or your older client with complex care needs, apply this. Is there a degree of iatrogenesis here? How can we prevent it? And we are going to talk about some of the interventions. Next slide. So I want to talk about, we've been talking about functional assessment, function rather than, disease states. We don't, in this kind of assessment, we really look at function, which is critical. Normal aging changes, acute illness, worsening chronic illnesses, hospitalizations, all of these can contribute to decline in the ability to perform tasks necessary to live independently in the community. And the segment of older adults in Oregon and actually in the United States, that is the fastest growing segment, is 75 plus and 85 plus. So think about that. The information from a functional assessment can provide objective data to assist with targeting individualized rehabilitation needs or to plan for specifics in services such as meal preparation, nursing care, homemaker services, personal care. So if you don't have a good functional assessment, how are you going to develop your plan? The functional assessment can also help the clinician focus on the person's baseline capabilities, facilitating recognition of changes that may signify a need for additional resources or for medical workup. So if you don't have a baseline, it's difficult for you to actually gauge, hey, what's the difference? What's changing? Activities of daily living are basic self-care skills akin to all this, that the kind of skills that people usually learn in adulthood. And we're going to talk about them. And the more complex skills are referred to as instrumental activities of daily living. So you're assessing those too in your functional assessment. Next slide. And so here I'm just giving you a few tools, and we'll be talking more about them. For example, looking at functional status, you should review at your ADL'S and instrumental activities of daily living. Cognitive status, have some kind of baseline from some screening tools such as the MOCA or the SLUMS. For mood or affect, use the Geriatric Depression Scale. So falls risk, it is get up and go, or the tug test. So we're going to go over all of this, but I'm giving you a flavor for what are some of the standardized screening tools that you can use as a professional or a paraprofessional working with an older adult clientele. Next slide. So here are the major components. Functional capacity that you should be assessing. Functional capacity, falls risk, cognition, mood and fears, polypharmacy, social support, finances, goals of care, and advanced care preferences. That's a long list. Next slide. In addition, you should also add nutrition and weight, urinary continence, sexual function, vision and hearing, dentition, the kind of living situation they're in. Like, remember Karen, she lives alone. Purpose and meaning, and spirituality. Impose the 4 M's framework on what I just said. Next slide. And these would be some key questions to ask. Ability to perform functional tasks, or do they need assistance? What is their fall history? Are they incontinent? Are they in pain? What are their sources of social support? Do they have symptoms of depression? Are they having vision or hearing difficulties? Even more important if you're living alone. And whether the person has specified, has a durable power of attorney for healthcare or advanced care planning. So I am now going to really move to, the next slide, to actual, what are the components. So what is a functional status? It refers to the ability to perform activities necessary or desirable in daily life. Remember I talked about the ADL'S and the IADL'S. It is directly influenced by health conditions, particularly in the context of an older adult's environment and social support network. Remember Karen. She lives alone, she had a fall, she's fearful and calling her daughter anxiously several times a day. Changes in functional status. For example, not able to bathe, not able to get in and out of the bathtub safely. Any change in functional status should prompt evaluation and intervention immediately. Next slide. And here is just a tip. Small changes in function make a big difference in quality of life for the patient and their caregiver. And this is for older, even small changes. For you, it may be insignificant, but for a frail elder, they can make a huge difference in their quality of life. Next slide. And here I'm just giving you, the list of basic activities of daily living, so that we are all on the same page. Eating, bathing, dressing, toileting, maintaining continence, grooming, feeding, transferring. These are all what we call basic activities of daily living. And then we have, next slide, something called instrumental activities of daily living. These are activities that refer to the ability to maintain an independent household, which includes shopping for groceries, driving or using public transportation, performing housework, doing home repairs, preparing meals, doing laundry, taking medications, managing medical emergencies, handling finances. Can you see? These are higher level independent, higher level activities for independent living. And when I talk about shopping for groceries, it's not just the act of shopping for groceries. There's a lot of back-end cognitive bandwidth, involved in shopping for groceries, correct? You need to know what to eat. You need to know when to go shopping. You need to budget. You need to follow a medical diet. You need to know how to store food appropriately. You need to know how to use appliances like your fridge or your stove. So this is just a shorthand, but it's actually involves a lot of cognitive abilities to do all of this, all of these instrumental activities, and also the physical ability to carry them out, or that you can make appropriate arrangements if you cannot carry them out. So very, very important, and that's why they're first. This should be very basic assessment that you need to be doing. So next slide. So what are some applications of this? Like, we want to assess medical self-care if they're living alone. Can they manage their medications? Can they monitor their chronic illness like diabetes or COPD? Can they keep their health appointments? Do they know when to call in an emergency? Independent self-care. Can they take care of their activities of daily living? Can they maintain a safe living environment? Can they manage emergencies? If they have chest pains, do they know to call 911, communicate with the operator what's happening to them, and give them their address or whatever else the dispatcher needs? And everyday financial management. Do they know how to pay their bill? Do they know how to budget for groceries? So these would be practical applications of those basic activities and instrumental activities. So next slide. So the tools that we recommend are the CATS index for ADL'S and the Lawton scale for instrumental activities of daily living. And these are free. You can just Google them and you can download it. And I can talk to both Angela and Kelly later to see if they want to send you these tools. But these are a recommendation that I would have. Falls risk. It's part of this, basic activities of daily living. And why am I bringing it to your attention? Because 1 in 3 Oregonians falls over the age of 65. So it's a huge problem. So that means almost 34% of older adults in Oregon fall. And patients who fall or have a gait or balance problem are at high risk of having a subsequent fall and losing independence. So think about Karen again. An assessment of fall risk should be integrated into the history and physical exam routinely. Gait speed, how fast you walk, predicts functional decline and early mortality in older adults. Assessing gait speed in a clinical practice may identify patients who need further evaluation, such as those at increased risk for falls. So screen for falls. Next slide. When you see patients over the age of 65, ask these 3 questions as part of your routine exam. Next slide. Have you fallen in the past year? Do you feel unsteady when standing or walking? Do you worry about falling? If your patient or client answers yes to any of these key screening questions, they are considered at risk for falling, and further assessment is recommended. Imagine if we had asked this of Karen. Next slide. And here are some other tests which you can request a physician or a nurse practitioner to complete. Ask the provider to measure blood pressure, orthostatic blood pressure, which is one of the primary reasons for falling, by the way. When your blood pressure drops and you feel kind of dizzy and woozy and you can fall. Time up and go, or tug test. 30-minute stand test for leg strength and endurance. And then the 4-stage test to assess static balance. So these are actual tests that you can request. So now we are moving on to cognition. The incidence of dementia increases with age. So in the United States, it is the signature disease of aging, particularly among those over the age of 85. And what did I tell you about demographic trends? That is one of the fastest growing subsections of the older adult population. So not only are we aging, we are aging and living longer. We're aging, living longer with dementia. Yet many patients with cognitive impairment remain undiagnosed. In fact, recently, the Alzheimer's Association released a study which said that only in primary care settings, only 16% of patients were ever screened for cognition, in where large numbers of older adults came. So the value of making an early, next slide, please. The value of making an early diagnosis includes the possibility of uncovering treatable conditions. So, there could be what we call pseudo-dementias, that if you rectify whatever the underlying causes, that the person's cognition will improve. Again, remember the 4 M's. Mentation was a big part of it. Here are some screening tools. SLUMS, St. Louis University Mental State, which is in the public domain. MOCA, they recommend a brief video training before you use it. Mini-COG, clock drawing, they are shorter tests which are good for busy clinicians, but screen for cognition. Next slide. And so again, just a quick word about dementia for some of you who may not know. Again, it's the disease that attacks the brain and destroys brain cells and functioning. So it's neurodegeneration. Dementia is an umbrella term, and there are many kinds of dementia, just like cancer is an umbrella term, and there are many kinds of cancer. And Alzheimer's disease is one of them, which is the most common one in the United States. It causes problems with memory, thinking, language, behavior. The sad part, it is progressive and irreversible, which is a core feature of neurodegeneration. And currently, there is no cure for it. And it's in the top 10 killers of Americans, dementia is. Next slide. And so this is what gets affected in dementia. Look at it. Learning and memory, language, attention, judgment, reasoning, how fast you can, your reaction time and your speed at processing information. Also your visual and perceptual, motor gets affected. And look at executive functions, which are required for those instrumental activities of daily living, planning, responding to feedback, inhibition, mental flexibility, task initiation, organization, self-regulation. All of this gets affected in dementia. I'm not saying all of it gets affected at the same time, but remember, dementia is a progressive disease. So as the disease progresses, more and more domains get affected. And also, it's also dependent on the kind of dementia you have. Next slide. And this is just profound that, it is a brain disease. Your brain is the consistence of jello and it weighs only 3 pounds, but it is the most powerful organ in our body. Next slide. So, ability to perform ADL'S and IADL'S is dependent on cognition, like reasoning and planning, your motor, your balance and dexterity, and perceptual, including sensory ability. So can you see how integrated it is? Important distinction is that the individual's ability to complete the task versus the ability to recognize that the task needs to be done without prompting. That's the key. And functional impairment can cause cognitive decline to accelerate. Very important. So they are kind of, a vicious cycle. As your cognition declines, your functional impairment increases, and as your functional impairment increases, your cognition, cognitively also you decline, or it gets accelerated. So how important it is to first of all recognize and have a baseline for these activities, and then to preserve those functions in terms of your care plan. Next slide. So I'm now moving on to mood disorders, depression. Late life depression remains underdiagnosed and inadequately treated in older adults. Depression in older adults may present atypically and may be difficult to assess in patients with cognitive impairment. A 2-question screener is easily administered and likely to identify patients at risk when either question is answered in the affirmative, and that is the PHQ-2, which is, during the past month, have you been bothered by feeling down, depressed, or hopeless? During the past month, have you been bothered by little interest or pleasure in doing anything? And I would challenge all of you on this phone, on this Zoom conference today, whether you're an aging service case manager, or you answer, or you are an options counselor in an ADRC, or you work in a community mental health program, or wherever you are. Anyone can ask these 2 questions for depression, and you don't have to be a qualified mental health professional. This is where you're identifying someone who is having a depression. I already told you it is underdiagnosed and inadequately treated, and inadequately treated depression has a cascading effect on all other diagnoses and on health outcomes and on functioning. So asking these 2 questions is, yes, it is part of the comprehensive assessment, but you could also be asking this question wherever you are in whatever setting. And again, I want to emphasize, you don't have to pull out a sheet of paper and start, put check marks, which can be kind of a barrier sometimes. You can slip these questions into your conversation. After, if they answer in the affirmative, that's when you can refer to a full evaluation, which should anyways be part of a comprehensive geriatric assessment. Next slide. So a positive screen should be supplemented with the 7 additional questions to complete the Patient Health Questionnaire 9, which is the PHQ-9. The PHQ-9 has increasingly been used to detect and monitor depression symptoms among older adults. So it is a reliable and valid measure for depression severity. How many of you use PHQ-9 regularly, and how many of you who are mental health QMHPs or therapists actually use the PHQ-9 as a treatment outcomes tool? But there are other screening instruments too, such as the geriatric depression scale. In short, we call it GDS. GDS 15, which is a shorter version. There's a 30-question one, and then there is a 15-question one. And I know many people tell me, Nirmala, my client or my consumer has vision problems. She's not going to read 15 questions. You know, when I was the geriatric mental health specialist for Clackamas County, I would frequently read the questions and ask them to say yes and no, and I would complete it. So it's absolutely okay for you to actually read the questions and ask them to say yes or no and complete the form. By the way, PHQ is also a required instrument in licensed nursing facilities. It's part of the MDS, you know, the minimum data set that they have to screen for mood, for depression. And so nursing facilities also use PHQ-9. So it is used widely, and it is an absolutely valid measure for depression. In fact, I saw a comment in the chat box. Someone said that they are a PEARLS provider. That means they provide this evidence-based treatment for depression to older adults, which is an outreach model where they go and meet the persons in their home and provide this treatment. And that clinician said that they use PHQ-9. So yes, not only it is used to identify depression, but it can also be used as a depression outcome tool, which means essentially that you create a baseline of disease severity. How depressed are they based on the PHQ-9 on day 1? Then give your treatment, whether it is cognitive behavioral therapy, medications, behavioral activation, whatever you're doing for your client. And then maybe 6 months later or 3 months later, you give them the PHQ-9 again to see whether there's been any improvement. So if there's improvement, you can say that whatever you're doing, the treatment is helping this person. If there is no improvement, you need to get back to the drawing board and see what is it that you should be doing differently. So that way it can also be used as a outcome measure. Next slide. While we are on the subject of depression, have this awareness because we just observed a suicide prevention month in September. And, one of the groups at highest risk for suicide is older adults and 65, and then the highest group is age 85 white males. And so this is a nice framework to use. It's an easy way to remember to screen. This is developed by a psychiatrist at the University of Rochester. His name is Dr. Yates Con. It's the 5 Ds of older adult suicide. So demography. Remember I said the highest risk is white males who are unmarried or single or unpartnered. They have depression. They have significant physical illness, so disease. They are disconnected That means they're socially isolated or have very low social networks, and they have access to deadly means. So more than half of these the white males who commit suicide use a gun or firearms. So the 5 Ds are demography, depression, disease, disconnectedness, and deadly means. So this is a nice framework to carry with you. And again, superimpose on this the 4 M's of the age-friendly health system. Remember, one of the M's is mentation. And mentation includes screening and treating depression. And what all the data suggests is that older adults who die by suicide, 71 to 97% had a psychiatric illness, and most often it was a depression. Next slide. And here is just one of the leading suicidologists in America. His name is Dr. Joyner. This is his theory of why people die by suicide, and I think it really applies well to older adults. He talks about these 2 things are present in people who are actively thinking of dying by suicide. One is the sense of thwarted belongingness, that I don't belong. And the other one is a perception of burdensomeness. I'm a burden to my family, to society, or whatever it is. And this frequently drives suicide, especially in older adults. And so I just wanted to bring this up. His theory is called the interpersonal theory of suicide, Thomas Joyner. Next slide. So we've talked about the importance of screening, identifying, and treating depression in older adults in a comprehensive assessment, which fits very nicely with the 4 M's framework for age-friendly health systems, particularly screening for suicidal ideation and suicide risk, using perhaps the 5 Ds framework that I mentioned. And now I want to move on to polypharmacy. Remember, we talked about iatrogenesis. That is something that healthcare professionals create, which has a harmful effect on older adults. And one of this is polypharmacy. Absolutely something that is preventable. Older adults are often prescribed multiple medications by different healthcare providers, putting them at increased risk for drug-drug interaction and adverse drug events. The clinician should review the patient's medications at each visit. The best method of detecting potential problems with polypharmacy is to have patients bring in all of their medications, not just prescription, even non-prescription, vitamins, whatever supplements, whatever they're taking, in a brown bag. It's called a brown bag audit. It's not rocket science. Discrepancies between what is documented in the medical record and what the patient is actually taking must be recognized and reconciled. So this is a very simple intervention which we all can do. Again, I refer you back to the Comprehensive Geriatric Assessment's core principles. We want to focus on function and not the disease. If there are 15 medications, let me tell you, I have seen people with 15 and 20 medications. Each of them are interacting with each other. How many of you have heard of prescription cascades, where your client or consumer is on multiple medications, seeing multiple prescribers? They are actually having an adverse drug reaction or a drug-to-drug interaction. They go to one specialist. They think it's a new symptom, not a drug-to-drug interaction. And what do? They prescribe yet another medication for that symptom, which is actually a drug-to-drug interaction. We call that a prescribing cascade. And that happens over and over and over again. And what does it result in? Is iatrogenesis, what I talked about, you know. Next slide. So that is why we need the Beers criteria. I have the site here where you can go and download the latest version of the Beers criteria, which is 2019. Beers is essentially the name of the physician who created this list of medications, and they have been stratified by risk in terms of use with older adults. And we as an initiative, of which Angela is a part, are actually promoting the use of the Beers criteria. And all of you who are on this training today, if you don't have it, I would strongly urge you to download the 2019 Beers criteria and please distribute it to the rest of your team. Older adults respond differently than younger adults to medications due to changes in medication absorption, distribution, metabolism, and elimination that occur over time because of our aging bodies and less efficient organ systems. Older adults can also have more or less sensitivity to medications. These unpredictable age-related changes often increase risk for adverse effects and drug interactions. Again, think of the 4 M's age-friendly health system. One of the M's is medication. It is so important for us to be aware of what are medications which are to be avoided, what are appropriate doses, the practice of cascade prescribing, all of that. The Beers criteria is a unique set of evidence-based recommendations tailored specifically for older adults. And it's for all care settings except hospice or palliative care. The list of potentially inappropriate medications, so sometimes you see this acronym PIMS, which means potentially inappropriate medication, provides guidance on how to optimize medication selection in older adults, and it can help meet a variety of healthcare needs. And it is a core feature of Comprehensive Geriatric Assessment and of the 4 M's age-friendly health system. So one is the Beers criteria. Next slide. And there are some other additional tools. One is called STOP, Screening Tools of Older Adults. So STOP stands for Screening Tool of Older People's Prescriptions. And the other one is called START, Screening Tool to Alert to Right Treatment. And these were first published in 2008, and you can download them. Just put in STOP and START criteria, and you can see the two. Again, I can't emphasize that polypharmacy is preventable. It contributes to falls, to depression, to worsening dementia, to overall decreased functioning, impacts quality of life, and it's preventable. So my challenge to all of you would be, are you regularly doing that brown bag audit? Are you checking and coordinating among multiple prescribers? Are you looking at function versus disease? So all of those things I would alert you to. Next slide. So the next in the comprehensive geriatric assessment, and this has gained wide priority, not just more so in COVID-19, but prior to COVID-19, this whole concept of social isolation and social support. We sometimes call having a strong social support network your social capital. The existence of a strong social support network in an older adult's life can frequently be the determining factor of whether the person can remain at home or they need placement in an institution. A brief screen of social support includes taking a social history, determining who is available to help if he or she becomes ill. Early identification of problems with social support can help with planning and timely development of resource referrals. And I'm hoping all of you on the phone today who work with older adults, that this is a core part of your assessment, social support. Next slide. Look at this. 43% of seniors feel lonely and sometimes I know we conflate social isolation and loneliness. They're two different things, but I'm just giving you some statistics here. 43% say they feel lonely. 45% at increased risk of mortality in those seniors who report feeling lonely. And loneliness is more dangerous than obesity and as damaging to your health as smoking 15 cigarettes a day. So it has real consequences on health and well-being. So my question to you as practitioners, providers, all of you on this phone call today, managers, how are you addressing social isolation and loneliness in your communities or within your patient panel or your clients? Because the consequences are real. Next slide. So what does the science say about this social isolation? As a force in shaping our health, medical care pales in comparison with circumstances of the communities in which we live. Few aspects of community are more powerful than is the degree of connectedness and social support for individuals. And all of this has really been brought to the forefront during this pandemic, where we had those really restrictive stay-at-home orders and how it impacted our mental health and our mental wellness. Imagine living with that all the time. Living alone. Now, these are the risk factors, all of you who work with older adults. Living alone. Being unmarried or single, divorced, widowed. No participation in social groups. Few friends. Strained relationships, whether it's familial or others, are not only risk factors for premature mortality, but they increase risk for loneliness. So take a look at your clients, at your panel, at your list of consumers. How many of them you would say would be at risk of social isolation and loneliness? Do you know that? What specific interventions are you connecting them to? Again, think of Karen. Who was her only social support? Was her daughter. Next slide. Through our initiative, the Older Adult Behavioral Health Initiative, of which Angela is a part, we are recommending the UCLA 3-item loneliness scale to be used as a screening tool, and I've included it here. Again, this should be part of any comprehensive geriatric assessment. Next slide. Now I want to move on to goals of care. That's, you remember, that's a principle of comprehensive geriatric assessment. Goals of care often differ from advanced care planning or preferences that focus on future states of health that would be acceptable and determination of surrogates to make decisions, such as, advanced care planning documents, living wills, medical treatments. Generally, advanced directives are framed in the context of future deterioration in health status. So this is not what goals of care is about. By contrast, a patient, consumer, client's goals of care are often positive. For example, regaining a previous health status, attending a future family event, frequently social, living at home, maintaining social activities, and functional, completing my ADL'S, being able to walk outdoors. And they assume priority over health-related goals, such as just surviving. They're also patient or client-centric and individualized. For example, regaining independent ambulation after a hip fracture may be a goal for one patient, whereas another might be content to use a walker. Both short-term and longer-range goals should be considered, and progress towards meeting those goals should be monitored, including reassessment if goals are not met. And how does this fit into that 4M's age-friendly framework? What matters? The M, what matters? That's what goals of care are. It's not about curing the disease or controlling your blood pressure or your A1C should be below this. It's really what matters to the person. That is the goal of care. For example, I want to attend my grandson's graduation, or my son is getting married next year, next July. I need to be at his wedding. That would be the goal of care. Next slide. So it's very different from advanced care planning. So I want to make that very clear in this training. And then we have advanced care preferences or advanced care planning. Clinicians should begin discussion with all patients, clients, consumers, whatever you call them, about preferences for treatments while they still have the cognitive capacity to make these decisions. These discussions should include preparation for in-the-moment decision-making. Could you just move forward? These discussions should include preparation for in-the-moment decision-making, which includes choosing an appropriate decision-making or a surrogate, person for durable power of attorney or healthcare representative or someone, a proxy. Clarifying and articulating their values over time and thinking about factors other than the patient's stated preference. As example, patient who wants to extend their life as long as possible might be asked about what should be done if the patient's health status changes and doctors recommend against future treatment, or if it becomes too hard for loved ones to keep them at home. Advanced directives help guide therapy and treatment if a patient is unable to speak for him or herself and are vital to caring optimally for this population. So all of you on this phone call today, how comfortable are you in having this conversation with your older clients, patients, consumers? Do you have it routinely? How about as a community, Central Oregon? There's a whole grassroots movement about talking about death and dying. How many of you have heard of death cafes? As a culture, we don't talk about this. And what happens is, if you look at all the data from Medicare, that most of the Medicare expenditure is happening in the last about 3 months of life, because people have not made their wishes known clearly. And all kinds of treatment is thrown at the person. And totally medically futile, increasing pain and suffering because we didn't talk about what our wishes were. So I would really urge each one of you as healthcare professionals, professionals, or maybe you are a family member attending, to have this conversation, and have this conversation early if you're an adult child and have aging parents, where they still have the capacity to let you know what their wishes are. Or I'm going to be bold and ask all of you on this training, how many of you have an advanced care directive in place? Do you have a healthcare representative designated? So these are very important conversations, and I would suggest to Angela that one of your future trainings should be on having this conversation. So there's a training that one of my colleagues gives called Conversation Ready. Are you conversation ready to hold this conversation with your clients or with your actually family member, or looking at yourself? Next slide. And I just want to all of you may know the difference, but there are a variety of people attending today. So I just want to make clear, what's the difference between a POLST and a living will or advanced care directive? A POLST is a one-page form that focuses only on immediate treatment. It's best for our health emergencies because it's a medical order signed by your primary care physician or nurse practitioner. That means EMTs and hospital must do what the POLST form specifies. It's usually recommended for terminally ill or very frail seniors who have made their end-of-life wishes clear to their physician or nurse practitioner. So that's the POLST. And it should be handily available in a medical emergency, so that EMTs and all know what to do. A living will, on the other hand, is a legal document that contains your end-of-life preferences when decisions have to be made about future treatment. A living will guides the healthcare agent or healthcare representative that you appoint to make choices that honor those wishes. So this all has to be done in advance. That's why it's called advanced care planning. And it entails that the person completing this has the mental and cognitive capacity to complete the document and to appoint that healthcare agent. So what happens when you don't have this document? And you have a dementia crisis, you're very ill, you're in the ED. No, you can't do the advanced care directive then because you don't have the capacity, you don't have the cognitive mental capacity to complete it. It would be unethical and inappropriate. And at that point, then it becomes very difficult, especially in a medical emergency. There's a hierarchy of who can make decisions. But when there is no one in a medical emergency in a hospital, then it is the physician there who makes the decision. But very often I have different professionals calling and saying, Nirmala, can we just sign it now, or should we ask them to sign a, power of attorney? No, you can't, it's too late. Then you have to go the route of guardianship, which is very expensive and very difficult to process. So I can't emphasize this more, that as a culture, we need to be talking more about death and dying and what it means to live well and die well, having those conversations, and then actually creating places where we can actually complete these advanced care directives. And that would be my challenge, Angela. And I know, Angela, some of your background is in hospice, that really looking at how can your Central Oregon community start this conversation. Next slide. So very briefly, this is not traditionally in a comprehensive geriatric assessment, because generally it's done for more frail people. But I'm including this. Remember, we talked about social isolation learning, that doing a driver assessment would also be a good thing. It's normal and inevitable to experience age-related symptoms that make driving more difficult. Older drivers may be dealing with vision or hearing problems, not to mention reflexes that aren't as sharp as they were once. In addition, they could be suffering from serious chronic illnesses that can impede their ability to drive safely, such as heart disease, arthritis, Parkinson's disease, or even dementia. In fact, according to the CDC, drivers over age 65 are twice as likely as younger drivers to report having a medical problem that makes it difficult for them to travel and drive. And the risk of being involved in a deadly car crash starts to increase among drivers who are 70 years or older, with the highest risk among drivers who are 85 or older. In fact, yesterday on the local news in Kaiser, which is right outside of Salem, there was a news about a 93-year-old man who it was a hit. He hit a pedestrian. I don't know all the details, but basically, the risk increases as the older you are in terms of driving. More worrisome, drivers 80 and older have the highest crash death rate than any other group except teenagers, according to the CDC. So it's a good thing to do a driver assessment or even talk about driving and with your patient, consumer, or client. Next slide. And here could be some triggers for driver screening: changes in vision, in gait, and any kind of other musculoskeletal changes, changes in memory or cognition as a whole. You're taking multiple medications, which can cause confusion or drowsiness or something else, and driving concerns that either the patient is expressing or family members are expressing. Or, is he limiting the driving? Has family expressed concern? This should all trigger an assessment. Next slide. And I want to include this slide on firearm safety. I just recently gave a training in Southern Oregon on dementia and firearms. Very important to ask these two questions. Are there firearms in the home? Are firearms kept loaded and unlocked in the home? And this is not just for suicidal, to prevent suicide. This is for safety. Because, in more advanced stages of dementia, you can have neuropsychiatric symptoms such as delusions, you can have confusion, you can get agitated, which are all the behavioral symptoms. You can mistake the identity of your caregiver as an intruder, pick up a gun and shoot them. So very important to ask this question and then implement a firearm safety plan. So that kind of completes what would be considered in a comprehensive geriatric assessment, with my two additions of driving and firearms. So I want to come back to Karen. We talked about Karen at the very beginning, and I asked you to keep her in mind. I am wondering, now that you've heard all of what we talked, if you want to put it in the chat box, any of you, what would be some things you would be looking for or talking about or assessing for in Karen? And Angela and Kelly, I'm just wondering if people can put that information in the chat box. We don't want to move to the next slide. I just want to see what people think. Remember, she's 85, lives alone, fell down the stairs. She's her to walk, calling her daughter repeatedly several times a day. And the daughter brings her to the doctor, and there's physically nothing wrong. I mean, there's no bruises, no broken bones. And Angela and Kelly, if you don't mind just reading out if any comments are coming in terms of what they would do.
Nirmala, we have a few here. We have
okay.
IADL'S and ADL'S.
Okay.
Social support, gait change, polypharmacy. Brown bag audit should be done to assess for medication interactions.
Mhm.
Changes in mood or cognition that would affect sleep or appetite.
Mhm.
Physical therapy assessment.
Mhm.
And falls assessment or depression assessment.
Okay, well, those are great suggestions. Thank you all. If Kelly, if you can move to the next slide. So remember, she brought her mother, the daughter brought her mother to the clinic. And so this is what they did at the clinic. They did the timed up and go, which remember I told you is a falls prevention gait balance test. It's called TUG. It takes 45 seconds. So she takes 45 seconds. Difficulty rising off chair, cannot advance without holding, sorry, not hooding, it's holding onto furniture in the office. So that was the result when they asked her to do the timed up and go. It took her 45 minutes. She had a very hard time getting out of the chair, and then she was holding on for her dear life, to the furniture. Then they did a screening for ADL'S, which is activities of daily living. And what they found was overall she was doing okay, but she needed help with toileting and with eating. Remember, she had actually stopped eating or was eating very poorly since she fell. With instrumental activities of daily living, she was not doing badly, 10 on 14. But where they found was problems more with finances, so she was having problems with some of those more advanced IADL'S like budgeting and, managing her finances. Cognition, I don't know what test they used, but it was basically 20/30, which puts her kind of like in the moderate range of dementia. They said she had short-term memory problems, some visuospatial problems with calculation. So no wonder then, she needed help with like finances and budgeting. Look at her depression scale, GDS. Remember, I said that is the short form of the geriatric depression scale. She had 8/15. And then social. They evaluated her social network or social milieu. Daughter is 55 years old, lives with husband who has lung cancer, and she's his caregiver of the husband, can take her home only on the weekends. A niece is available twice per week. And as you can see, her socioeconomic status, she's fairly poor. She only has maybe social security benefit, I'm not sure, $600 a month. So can you see this clinic evaluated her gait and balance, ADL'S, IADL'S, cognition, depression, social. So it's fairly comprehensive. Okay. Next slide. So what did they come up with? Impression post-fall syndrome, which is fear of falling, fear of loss of independence. And it's a kind of anxiety. In fact, I teach a class on fear of falling. So I diagnosed her with fear of falling, post-fall syndrome. And guess what? Fear of falling puts you at even increased risk of falling again. So she had post-fall syndrome, moderate depression, moderate cognitive decline, which we said, she had 20/30, risk for malnourishment. She, as it is, she needed help with that. But then with her fear of falling, she was so afraid of getting up and doing anything. She was basically just sitting at home and not eating, not going shopping or, not cooking. And so that put her at risk for malnourishment. And what was the plan? And many of you put some of these suggestions right now in the chat box, physical therapy at home, occupational therapy home safety audit. Did you know Medicare pays for that? And one study said that the one intervention for which you will get the most bang for your buck for in terms of falls and falls prevention, remember I told you 1 in 3 older adults fall, is a occupational therapy led home safety audit. Antidepressant treatment, which is a catch-22 because some of those SSRIs are actually put you at fall risk, but she has significant depression. And so the suggestion would be to go low and go slow. That means using a geriatric dose and don't titrate it like, you know, boom, 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 that very slowly. To arrange for some kind of in-home caregiver to help her with like bathing and, you know, with her finances, because she has problems in that area of her IADL'S and ADL'S. Also to do some light housekeeping and meal preparation or arranging for meals for her because she's at risk for malnourishment. And she actually meets the criteria in terms of meals testing for income. And maybe referral to a senior loneliness line for social isolation. Remember, she is calling her daughter repeatedly. Her daughter is already caregiving for her husband who has cancer, and she herself, you know, is caught in the middle. You know, they may have children, I don't know. So what other supports can you put in for loneliness? And I'm asking this to all of you on the phone, on this training. You can put it in the chat box. I have said refer to senior loneliness line when someone would call her, you know, on the phone and chat with her. Are there anything else that you can think of that's available in your communities? Someone is saying peer support, others are saying peer counseling program, again, peer support. You know, you can even use faith community volunteers from your local church. And of course, COVID-19 complicates all of these situations now. You know, checking whether she has technology that she can use, I don't know. You know, does she have just a basic phone? You know, those would be all of the kind of in-depth assessments that would be required to create this treatment plan. Someone said friendship line, which is another senior, kind of like the senior loneliness line, a friendship line. Church support for walks. Someone said someone could come from the church and help her walk every day. Which would be kind of like a killing 2 birds with 1 stone. Not only is it giving her some companionship, but it's also strengthening her legs. Remember, she's afraid now of falling, so she's sitting and not doing much, which is resulting in, guess what? She's losing any strength that she may have had in her lower body because she's not exercising, and that then puts you at greater risk for fall. So what does this case study show you? If she had come in to a regular clinic, they would have checked her for her bones, for bruises, maybe given her a pain medication and sent her home. Would it have done anything for her? No, she would probably have fallen again. She would have kept falling until she landed up in a nursing facility. And you know, if you break a hip when you fall, when you're older, it's a terminal diagnosis, or it's the leading cause of traumatic brain injuries, falls in older adults. So if you already have moderate dementia and you fall and hit your head, what's going to happen? You're going to accelerate cognitive decline, leading to institutionalization, poor health, and early death. So this case, you know, is really illustrative of how important it is to really look at all of those dimensions impacting this person. Her home environment, her social environment, her mental state, you know, her mentation, you know, she's experiencing post-fall syndrome, her physical health and diagnosis, all of them interacting and then developing the plan of care. which will address all of that so that she can continue to stay in her home and perhaps even thrive once any of this is addressed. I know here in this case study, I did not mention it, but they are only trying her for putting her on an antidepressant for depression. But typically older adults don't get referred for talk therapy. It's kind of like a bias in our healthcare system that older adults don't get referred for talk therapy, which are extremely effective in older adults. So cognitive behavioral therapy for falls, for depression, that would have also been totally appropriate for this person. So I would also include that in this case study. And again, I'd like you to think back to the age-friendly health system framework, the 4 M's, what matters, mentation, mobility, medications. You can see how clearly all of these would impact Karen in a positive way if we were all adhering to those core principles for an age-friendly health system. Next slide. And next slide. I've just given you some ancillary documents. You can take a look at them when you get the slides. Basically, just some recommendations for best practice in geriatric medication. Do not prescribe a medication without conducting a drug regimen review. Simple principle, but difficult to. Could you go back one slide, Kelly? Yes. Do not assume a diagnosis of dementia in an older adult who presents with altered mental state or symptoms of confusion without assessing for delirium or delirium superimposed on dementia. Okay? Remember the mentation part of the 4 M's. Rule out depression, dementia, delirium. Avoid using prescription appetite stimulants or high-calorie supplements for treatment of anorexia or frailty in older adults. Instead, optimize social supports, what we were just talking about. Discontinue medications that may interfere with eating. Provide appealing food and feeding assistance, and clarify patient goals and assessments. So these are just some simple recommendations. Next slide. Again, some other screening instruments which are recommended are here. And my final slide, if you can just move, is my thank you to all of you for attending today. I appreciate your attention and your staying with us. And I have included my email here. I welcome questions. If there's anything I can do to help you connect with a resource, or you just needed to clarify something with me, you have my email here today. My hope is, again, what I said at the start, which were my learning objectives, that you go back and take what, could we just move to slide number 2, Kelly, if that's possible? That you have a better understanding today of what is a comprehensive geriatric assessment, the importance of it, especially when we looked at Karen. You now understand what are the domains and how they are interconnected in a geriatric evaluation, and what are some tools that you can use to enhance your evaluations. And Kelly, if you can move to slide 4, which is the age 4 M's framework. And again, I want to leave you with this 4 M's framework, which essentially is what matters: medication, meditation, have about 10 minutes for questions or comments, or, I'm open to a conversation. So you can remove this and we can just move to a gallery view or however you want to handle it. So if there are any questions, I thought I saw some in the Q&A. Terry says some people do not have anyone to act as decision makers for power of attorney for legal, medical, or end-of-life care. Often they are without financial resources. Hospice often wants this documentation. How would you suggest the best way to proceed? Advanced care directives often won't cover this or isn't necessarily accepted by some MDs. So Terry, advanced care directives are a legal document. So it is, if you have one, it's a legal document and you are actually appointing a healthcare representative. So I am not sure why MDs don't accept it. They should, it's the law. So I think it would be a matter of really educating that this is a legal instrument, it's a legal document, the advanced care, like the living will. But of course, it's a problem when you don't have one and there are no resources. I totally agree with you. It's a huge problem. Very often, if people are in that state where they don't have resources, they don't have family members, and they are kind of in a medical emergency or a lingering medical emergency and are in a healthcare setting such a hospital, so those cases can go to an ethics committee, then that makes a decision for them. Or in a medical emergency, then unfortunately then the decision making falls on the physician. I don't know whether I answered your question, but that would be my answer. But the subtext is how important it is to have this conversation wherever you are, in whatever role you are, to start creating that culture that we all are talking about this, especially when we have an aging society. Are there any other comments, questions, Angela or Kelly? Do we have any other comments, questions, or anything else that I can answer? Someone said, can you show your email again? Church, I'm just looking at changes in mood and cognition. Someone said, I would love an opportunity to attend a conversation ready training. So Angela, you have it there.
Thank you for all your wonderful ideas. We knew we'd be bringing you back. We just didn't know for what.
Yeah, yes. So,
oh, and there's a question about beer's presentation this Friday. I don't want to get us off track, but the answer to that one is no, that one has been postponed. But Nirmala will be presenting for us again at the end of the month and then also beginning of November. So if you found your way to us by accident and you're not receiving our flyers, please reach out, make sure we get your email so you can get the invites to the rest of the fall trainings that Nirmala is giving us this year.
And my hope is that, many of you commented, I just saw the chat, that you found this very interesting. This is a really great information. I'm hoping that you take this information back to where you work. And yes, you can make individual practice changes, but the better way to sustain that change long-term would be to really see how can you as an organization or as a healthcare provider change your practice. And if any of you need help with that, please contact us, either myself or Angela. We'd be happy to talk with you about it.